Our meeting of Tuesday, February 28th for ZSFG today. Welcoming everybody and asking for you to call the roll.
Yes, sir. I'll start with you, Commissioner Chow.
Present.
And Commissioner Green.
Present.
Great. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the January 24, 2023 ZSFG JCC meeting minutes.
Yes, please. We're prepared for the acceptance of the minutes on motion.
So moved.
And I would second. And is there any public comment?
Folks on the line, I see 2 people. If you'd like to make comment on item 2, the approval of the minutes, please press *3 now so we can recognize you. *3. All right, I see no hands, and since there's only 2 of you in the meeting, then that can be taken as an action. So we can move on to item 3, the regulatory affairs report.
Okay, thank you.
Thank you. Hopefully everyone can see the screen with the report.
Yes.
Okay. So hi, my name is Emma Moore, the Director of Regulatory Affairs. I think it says Adrian Smith on there, but I'll be presenting today. So for our report for February, I first want to note here that this includes data from January 14th through the 31st. And one of the things as we've been evaluating our data collection was that we were picking a somewhat arbitrary date, the Friday before the JCC report was due to end our reports, and we thought the data would be more meaningful going forward if we can collect it on a month-by-month basis so that you can easily compare January versus March or January 2022 to January 2023, etc. So this report is somewhat truncated because starting next month, I will have it on a monthly basis with just some highlights of things that have happened beyond that. So again, hopefully we can provide some more meaningful data coming out of that, but that is the rationale behind it. In terms of pending surveys, again, it's our consistent list. We are in the window. The 2 biggest surveys are the CDPH General Acute Care GACH licensing survey and the Joint Commission Accreditation Survey. Blessedly, it will be on next month's report because it happened in February, but we did have our Joint Commission Stroke Certification Survey on Valentine's Day and February 15th. And they did an absolutely tremendous job, the stroke team, and had 3 findings, which was all in all, I think we are very happy about that. They were all related to documentation, and at least one of the findings was documentation of neurochecks and vital signs, because 24 hours after a stroke patient comes in, there's quite a bit of scrutiny on that, as there should be. But we had heard anecdotally that up to 90% of hospitals going through this survey were getting that as a finding. So overall, we have 60 days to respond to those findings with our corrective actions. So you will be hearing much more about that in the coming months. But the stroke survey now has finally come off of that pending survey list. Other completed surveys, we did have an unannounced visit to the skilled nursing facility 4A related to a complaint about the discharge process, but the surveyor was in depth in her review, but the complaint was found to be unsubstantiated, meaning that there will be no further action related to that. We also received 1 plan of correction in January 19th, which we submitted related to a pressure injury that was reported I believe it was reported in August, but we got the plan of correction due to 2 tags. One was that we delayed reporting. There was a gap in communication that has since been addressed between the wound care team and the regulatory team. And there was also a policy that was beyond its 3-year renewal and review date. And I will just acknowledge, so we have monitoring items and action items related to both of those that we will continue to report out starting next month. I will also identify that there are a number of policies that have been going through the approval process that we are working. I would take this as the tip of the iceberg, and we are working very hard to get into compliance. To keep us moving, you can see our total reportable events here. We now have a new color for 2023, so green. So 1 elopement, 1 HAPI, and 1 retained foreign object, thus in the month of January in total in 2023. And I know there's been interest in the past of closed versus open events. Again, that is, we've had no major movement on that since the last time we talked about it. It is the state CDPH that controls whether or not the cases are open or closed. And I would estimate out of the 68 cases in 2022, there's, I think, at some point only 4 of them that they've officially closed. So again, they do tend to linger. We just got a call a couple of weeks ago about a privacy breach from 2016. So we're doing our best to stay on top of things, but in some cases there are some delays there. To go into a little bit more detail about those 3 events. So again, the retained foreign object on 4A was a 3-centimeter piece of gauze. But again, we took it seriously, and the surveyor is actually called about that one, and I believe will be coming out in the next couple of weeks to investigate in person. There was also a stage 3 pressure injury in the ICU, and lastly, an elopement in the emergency department. And I'm happy to report that after we reported that, SFPD, I believe, was able to make contact with that patient. So we just sent an updated report to the state to let them know. Lastly, plan of correction monitoring data. 2 of these, the Belmont and the hospital lab survey, I think have been consistent reports to this committee. So the Belmont has ongoing monitoring has to do with the HIPAA confidentiality training that's done on ELM. And the DPH compliant rate is now well above the 90% threshold that was set. And UCSF, I believe, is the UCSF providers are very close to meeting that threshold, but still trying to inch it upwards. So we will continue to monitor that, and the OCPA team is reporting out monthly at ALCC. So until we meet that threshold, we will continue to monitor that. The second case here is the HAPI, the HAPI from May of 2022. And in this HAPI, there was a challenge that it was not identified that the physician was notified when the wound progressed to a stage 3, nor was it identified and documented that a decision maker was notified of that. So an audit was done of medical records over a 3-month period, and 10 out of 10 or 100% of those monitored records were in compliance, suggested that the corrective actions we have taken have been successful in this. So the formal monitoring requirement has been met, but I know that the med-surg team and the wound care team are continuing to monitor compliance organizationally. And lastly, the Joint Commission Hospital lab survey from last summer. There are 2 things that they are working to report out, and at least one of them relates to the fact training and competency, and the training and the next competency check is due up in April. So you can see here that the next report will not be until May, to give them time to complete the competencies in April and then report them out to ALCC in May. So again, we are keeping an eye on them. That is why they are on the list, so that we don't let them fall off of our radar. So that concludes my official response for the report. What questions or comments can I field?
Thank you. Is there any public comment?
Folks on the line, we're on item 3, the Regulatory Affairs Report. If you'd like to make any comment, please press *3. I don't see any hands, Commissioner.
Comments and questions. I'm still trying to understand if the Regulatory Affairs Status Report for February includes data of January 14th. What is the March one going to include? I mean, we wouldn't have finished the March meeting. Are you going to include all of February? Is that it? It's going to be 1 month behind?
2 to 3, I guess 3 weeks behind would be the idea. Plus I can verbally provide any other information, but from a data collection standpoint, the idea, though certainly open to your feedback, would be that in March, we will provide the full month of February from a graphing and data standpoint, so that we can hopefully derive a more meaningful comparison.
Okay, Commissioner Green, comments?
Well, thank you very much. I think that's a great idea to help us organize our thoughts. I only had one question about the report, which is you have so many different teams and trainees that rotate in and out. So when you talk about notifying providers, is it clear in all the units which providers? I had a question later about even pathology, how you know with these teams changing month to month that you've actually identified the right people to contact.
Yes, so, and I think you're referring to, sorry for the scroll.
To the Hoppy where you said that the Hoppy where you said that there was a delay.
And what I will actually say is that I think this would be one, that there was an issue here, we needed to address it, but I will say in general, Epic has provided us with major progress. I used to work as a staff nurse back before we still had LCR, and trying to, you had a pager number and you knew someone would answer, but I couldn't frequently tell you who was on. But with Epic, you are actually able to see the team. And so I think that, and who's written a progress note, I find that very helpful as we do our quality investigations. So I would actually say we've made significant improvement in that particular regard.
And you feel that the staff, no matter which unit they're on, would know which of the members of the team to reach out to? Is there any uniform policy? Or, I mean, you've got fellows, you've got residents, you've got so many different, you've got attendings, you've got so many different layers. Is like a team leader, I'm sure it's different depending on the unit and the diagnosis, but is there any uniformity or any principle that guides that?
So there is, I believe, and if one of the providers wants to jump in to give more specificity, I certainly won't, would be okay with that. But what I will say is, yes, I think there's very clear delineation as to who's carrying essentially the pager. It might be an iPhone now, but that concept of who's on first. And in this context, specific to this HAPI, it really comes back to the documentation piece. And I think it's not that I'm calling saying my patient has a blood pressure of 200 over 100, I need orders. I would like to think there was a conversation about the progression of this HAPI, but from a documentation standpoint, I think that would be, if I was looking at the root cause of this, the potential gap. So.
Great, thank
And
you.
I can add a little bit of clarity to that too as well. I think one of the things that Epic, as Emma had pointed out, that's been sort of a great benefit of is that we have this option of secure chat within Epic, which is very much like texting. And so providers can use it on their phone, the computer, their iPads. And so this allows real-time messaging between the nurses and various team members. So it's not just one person, but it's really the entire care team of the attending, the trainees, other individuals who might be added to it. So it provides, I think, a richer story of the care team itself and everyone who's involved in that decision-making.
Great, thank you.
I think that's an interesting comment. Does that mean that everybody has a mobile device that allows them to do that?
That is an excellent question. So we have a nice framework that I'm happy to bring back to you that we use for how healthcare teams communicate with one another. So secure chat is only to be used for non-emergent, non-urgent issues. So for something like, Emma said, if it's, someone's having acute chest pain, they should page the person. They would not use secure chat. But with that being said, cell phones are ubiquitous throughout the hospital for all of our staff. And so we are utilizing that for communication, since everyone seems to have access to a cell phone, or at least checking in on the computer multiple times throughout the day for placing orders or for documenting their notes.
Oh, yeah, so because that kind of reminds me on how one tries to get through an airport nowadays. And if you actually don't have a smartphone, it becomes very, very difficult. But in any case, thank you. I was struck by one or two things, and I'm not saying that one or another process is correct, but looking at how Laguna provides a regulatory report and how we do here, it would be nice if we sort of use similar formats. I'd ask Commissioner Green actually what she really thinks, because what I'm finding right here is this is very clear to me, and it tells me how many things are happening, and where our where our plans of correction are. And I don't think we're really quite seeing that over at Laguna. So, on the other hand, Laguna has a FRI program. Of course, they have a lot more facility reports, but they do have a method in which they can tell us, going all the way back to 2020 or 2019, how many of these have actually been opened and how many have been closed, so that we're not only looking at 1 year in isolation, as you have given us. And that is useful because it actually can tell us, and Commissioner Guillermo has been very good at this, pointing out how many of those go back how many years and where we are with them. So recognizing that the state may be as far behind as you just pointed out in 2016, uh, we at least can get some sort of idea, since these seem to be very important nowadays in terms of maintaining our relationships with the state. So I don't have a solution. I don't know what Commissioner Green might actually have also felt, but I felt that somehow uh, uh, we put a lot of information out here about our plan of corrections and what's happening, but we don't really know how many fries are pending. Over at Laguna, we do know how many are and what types they are. In the breakout, very similar to what you have here. Um, we're probably not quite as clear about how all the plans of corrections are going. Maybe they have just too many. I don't know. But I find that kind of a contrast, as at least for myself. If I'm reading this, I feel comfortable, except for not knowing now that you're telling me that a few number of fries are still left. And when I do read over at Laguna, it's not quite as clear. So um, I know these are two separate institutions, and there are some uniquenesses for each of them. But that's my feeling about trying to read the regulatory report.
Got it. No, thank you for the feedback, and I think I will share that with Adrian. And I know that with Troy Williams, we've been sort of there's been much going on in the world at Laguna, but I know that the goal is very much to sort of share best practices from both sister institutions, so that things do align. So thank you for that.
So, Commissioner Green, you have anything to add to that, or a perspective also on how, when you're reading these?
Well, I think, before the pandemic, there seemed to be a rhythm to this where, the CDPH would come out and we had certain expectations for the most part that would be met in terms of resolution of various open events. And now it seems so haphazard. It seems that sometimes it's almost like the rain here. Sometimes you'll get this giant blitz and all these problems have been addressed, and then, radio silence for a while. So if we did know what the rhythm is, I mean, I do think it's the best of both worlds. I agree that the plans of correction are so numerous over at Laguna that we probably they would have a difficult time, I think, using this format. And they do have their own format for what they're doing in terms of their plans of correction and the recertification. But I think it would be very interesting to see the ebb and flow of how many items are open and where we are. It also may help give us a clue about whether we're in the big CDPH scope, where how important we are or where we are in their pecking order. But I would be quite interesting to know how far back things are open.
And that is one thing I will just add, is that as part of I tried to highlight it, but it wants to highlight all the lines. As part of our licensing survey for the General Acute Care Hospital, one of the things that CDPH shared at their California Hospital Association update in November was that they very possibly will be bringing a number of open cases, or potentially all of our open fries, and closing them at once during the survey, which honestly is a whole, like, I can't even quite process what that might look like. But I think they are I think having their feet held to the fire about how many things are open. And so it's potentially possible that once that survey does happen at a to be unknown to be announced date, that we may actually bump that number way up as to what is still open.
Be great.
Okay, well, thank you. I don't have any other comments. I think the report is quite clear, and I'll look forward to this new process of reporting by the month. Thank you. Shall we go on, Mark?
Sure. Thank you for that. Item 4 is a presentation harmonizing and synergizing access and flow across the ZSFG campus. a strategic A3 update. And Dr. Day, I will give you permission right now to.
Thank you, Mark.
Did you get that? No.
While Dr. Day is
Yeah.
bringing up the slides, I just wanted to thank Emma. Emma is newly appointed to her position, even though she's been with us for a while, and just want to congratulate her on her first survey, stewarding her first survey, which was the very successful stroke survey. So want to thank her for that and welcome her again to the role, which we're really excited about her occupying.
Very good. Thank you. Dr. Day.
Thank you, commissioners. Good to see you all again this afternoon. For the next couple of minutes, I'm going to be reviewing Jillian Otway and I's strategic A3 that focuses on patient access and flow across our entire ZSFG campus. As a frame of reference, we presented this probably about a year ago, really when we had developed our A3 and began the implementation of it. So this is really a follow-up to that initial A3. Our goals today is really one, to give you an update in terms of where we are on our metrics and how we're doing on them. But I think really to give you some tangible examples of the work that's been going on in several of our operational areas. And really, I think also to address how we're seeing the work moving forward over the next year. As you all know, we are very much guided by our true north here on the ZSFG campus. At the top, and I think this is true for every organization, is really our North Star, which is why we do the work that we do and what motivates us all here, which is our patients and our community. And then moving down at the base of our true north triangle is really what are our goals and our domains that we want to work on and focus a lot of our performance improvement work to help us achieve our overall mission, vision, and helping our patients and community. And so Jillian and I's strategic A3 focuses on the pillar of quality. And so we identified at an earlier Hoshin about 1 year ago that access and flow is going to be our quality pillar for one of our true north strategic goals. As by way of background, and I think both of you have seen this before, this is Jillian and I's ZSFG Access and Flow A3. The left-hand side, we have really sort of the background, the current conditions, but really what was the problem statement that we were trying to address after doing a really rigorous and robust gap analysis of our flow and access on the campus. And then on the right-hand side is really what were our countermeasures or our interventions that we had proposed to try to address some of our flow and access issues, but then really giving a detailed project plan. And so for the next couple of slides, I wanted just to provide an update on where we are with regards to this work. And then I think really, again, share with you sort of how we're envisioning this work moving forward. So our problem statement at the beginning of this work, after talking to multiple stakeholders, looking at several areas of data, several trends over the last several years, we came down to really one simple statement regarding flow and access on the ZSFG. That is, ZSFG lacks a clear and unified strategy for how to drive, improve, and sustain our improvements with respect to both access and flow across all of our operational areas. And if you remember the title of our talk in our A3 is Harmonizing and Synergizing Access and Flow Across the ZSFG Campus. And I think this problem statement really encapsulates that. In the past, we worked in multiple different domains. So inpatient, outpatient, radiology, worked in different domains in terms of how we thought about access and flow. The way our group had really envisioned this is really how do we bring all those groups together rather than working in parallel? How do they synergize? How do they harmonize that work to really overall improve the patient experience and patient movement across our entire, but also complicated system? We also wanted to simplify some of our metrics and really try to create a targeted focus approach for how we envisioned this work moving forward. So we identified 3 key operational areas: the emergency department, our Department of Care Coordination, and our adult outpatient specialty care clinics These are the 3 key areas that we thought if we could focus on one metric in each of these areas, this could significantly improve both flow and access across our campus. You've seen, I think, each of these metrics before, but just to quickly review, in the emergency department, we focused on our ambulance diversion rate. Within the Department of Care Coordination, again, a focus on our lower level of care, med-surg patient days. And then within our adult outpatient specialty care clinics, what are the proportion of our clinics that have a third next available appointment under 21 days? Just to review quickly, over to the right, we see what our baseline data was about a year ago with respect to each of these metrics. Currently, you can see that we are green with regards to ambulance diversion, but we are currently red with regards to our other 2 areas in terms of lower level of care patient days, and then the proportion of our clinics with wait time under 21 days. I'm now going to sort of drill down into each of these areas a little bit more in detail to give you a better idea of the work that's going on in these areas that has led to some of the successes, but also some of the challenges in the other areas, but also I think to provide some optimism in the work ahead in these areas that are still red. Now, at a high level, one of the things we had thought of as a group to try to improve communication and coordination of our access and flow work, we're really focusing on having a governance structure. So Jillian and I, together in concert with our leadership teams, put together an access and flow committee that hadn't met for several years to really bring a group together initially on a weekly basis, but now on a bi-monthly basis to really look at flow data, review countermeasures that each of the groups were working on with respect to their operational areas, but then also to provide a forum and sort of a roundtable for areas to talk about their challenges and opportunities. Having this group met just really beginning since November, one of the things that I think it has dramatically improved is communication among all of the services. People are not working in silos anymore. I think there's a lot of crosstalk. I think people are also aware of a lot of the work that is going on in several of the areas, but it really is also, I think, a phenomenal communication tool to disseminate information out to all of our operational areas, really around our focus on access and flow. And then one of our other big achievements is really around increasing our hiring of staff in several of our key operational areas. And we've made a lot of tremendous progress in this area, specifically with regards to the emergency department, our med-surg units, and our perioperative or OR space. Specifically, with regards to our physician side, we've expanded some of our team censuses, so increasing the number of physicians on our medicine and critical care services to help with the increased flow and demand over the last several months. And then also increasing nursing staff in several areas. And in particular, which was a brilliant idea from Jillian, was to utilize med-surg registry nurses in the emergency department where we have a high level of med-surg patients that are boarding. This has resulted in, I think, a lot of improved communication and collaboration amongst all of our services and has dramatically improved some of our flow in that area. So talking about some of our specific operational areas, one that I think all of you are acutely and keenly aware of is our ambulance diversion. We have spent many years discussing a number of countermeasures to try to improve our overall ambulance diversion, trying to get it below 50%. Right here is a detailed outline of sort of the PDSA that has been ongoing with regards to ambulance diversion in the emergency room. Rather than going into the details of it, I think one of the things I want to highlight around it that made this successful is, one, both our physician and nursing ED leadership teams came together to really relook at how we activated ambulance diversion. We gave autonomy to our groups to really think about how we wanted to go on and off, but giving specific parameters of how we wanted to do it, and really wanted to take a really collaborative approach to make sure that everyone within the emergency department felt comfortable with the PDSA, but understood the reason why we wanted to reduce our ambulance diversion. And essentially, we've gone to sort of an on-off system each day, that there are a certain number of allotted hours that we are given on a daily basis within our own system to go on diversion. And then once we utilize those hours up, we no longer will go on divert. This was implemented in September. And as you can see, it's had a very remarkable result. So If you kind of start over on the right-hand side, right around November, if you kind of look to the left of that, you can see consistently our ambulance diversion, even during the times of COVID, was about 60 to 70%. So very much off of our baseline target. Right around the time of November, December, you can see while it was at 60%, right at December, once we implemented this countermeasure, it significantly dropped down to 50%. And I don't have the data on here, but as of this month, we are now at 44% of ambulance diversion. So we are continually seeing a steady decline of our ambulance diversion by implementing this really robust and collaborative PDSA within the emergency department. Another area I'd like to celebrate that has improved access and flow is our skilled nursing facility, which is our 4A. And this really came about from, again, bringing together our leaders at the Access and Flow Committee. Our 4A leadership team had noted that many of our patients were being admitted to the skilled nursing facility at the end of the day, sometimes as late as midnight. And you can imagine both from a flow perspective, but also even a patient experience perspective, that this was not ideal. And so their leadership team came to our group and really proposed a PDSA of trying to standardize not only the checklist for referring patients over to 4A, but really setting a clear expectation and a time of when people needed to receive that checklist to admit a patient. And what you can see is this has had some dramatic improvement within 4A itself. So previously our mean admission time was about 5:30 p.m. And with the implementation of this standardized checklist with the specific time that it needs to be turned in by, we've reduced that down by almost 2 hours. So now patients are getting over by 3:30. This has resulted in, I think, one, we've seen some increase in our patient satisfaction scores in 4A, but also we've seen improvement in our staff satisfaction scores as well. This also has improved our mean discharge time for patients in 4A as well. And you can see this has been a more robust change, almost about 3 hours difference. Now, I want to talk about our other two areas that currently are off target, which is our specialty care clinics and our Department of Care coordination. And I really want to provide a snapshot of the data, but also I think some of the work that's been going on in these areas. Right here is our proportion of adult specialty care clinics, the number that have a third next available appointment under 21 days. You can see going back at about March of 2022, which was sort of our nadir on this, we were at around 42 of about 57 clinics that met our access measure. Now, this has steadily risen over the last couple of months. It's pretty much plateaued at around 48, 49, which gives us about an 85% of our outpatient adult clinics that have wait time under 21 days. Now, I want to preface this a little bit. So while 21 days is our target, if you were to increase from going from 21 to 25 days, that number would jump up to 96% of our clinics would meet that metric. So several of our clinics, actually the vast majority, are just within a couple of days of that target of 21 days. And as of today, we only have 2 clinics out of a total of 57 that have a wait time that is over 30 days. So a lot of remarkable work has gone into this. And just to highlight some of the achievements in these areas to get us to where we are today, we've increased the number of available clinics, but really through a lot of creative thinking. We've opened evening clinics for our specialty care patients. We've increased daily clinic sessions, and then we've even expanded to weekend hours for some of our clinics, knowing that this might be a better time for many of our patients. We've leveraged more of our educational classes to bring larger groups of patients in. We've definitely expanded telemedicine across all of our clinics, where about 20% of visits are now through telemedicine. And then, as always, going back to our True North pyramid, really using our lean principles to enhance clinic efficiency and operations to, again, really improve our cycle time, our flow rate throughout our clinics to ensure that we can provide the maximum number of visits per clinic session. Transitioning over to our Department of Care coordination, and we've talked about this for quite some time, is our lower level of care patient days for our med-surg patients. As you all remember, lower level of care are essentially patients who are still hospitalized but do not have an acute need, and therefore we can't bill for those patients and they remain within our for extended periods of time. You can see on this run chart here, The purple represents acute admitted patients, so those who are non-lower level of care, whereas the green is our lower level of care. Really starting from about August last summer, there has been a steady increase in the number of lower level of care days, and we continue to see this increase. This is due to a whole host of factors, one of which that I think we all are acutely aware of is the closure right now of Laguna Honda, but I think also some decrease in the number of disposition options for our patients in the community. In the past, we were able to meet this metric through a lot of outstanding work from our Department of Care Coordination team. We're hopeful that over the next several months and eventually with the opening again of Laguna Honda that we'll be able to turn these numbers around. But I just want to highlight, and I won't go into the detail, but our Department of Care Coordination team has really taken a thoughtful and robust approach to how we would address, I think, these unprecedented numbers. Right here is really how they've been thinking about sort of our external flow measure or external flow PDSAs that they are working on. So really, what are those external areas that they are working on to try to increase discharges for our patients? So working with Chinese Hospital, where we have a contract, working with our medical respite, working with our behavioral service teams. Again, really trying to engage our network partners and other partners in the community to help increase disposition options for our patients. And then, as you can see here, there's just so many countermeasures and PDSAs that are ongoing in terms of internally what we are working on to really trying to improve our lower level of care situation on the ZSFG. Some things that I do want to highlight, we have a dedicated lower level of care team that consists of a physician, social work, and utilization management nurse. This team meets on a daily basis to review all of our lower level of care patients, really trying to approach this from a methodical and thoughtful approach, but also trying to improve continuity of care. And really have done a great job, I think, in terms of keeping these numbers from not increasing too much higher than where they currently are. So next steps. So where do we see as a group our access and flow work moving towards? So 4 key things. One is we really want to continue to expand and leverage our lean tools, but also the support of our KPO for helping our ZSFG Flow and Access Committee. So really, again, we have all our key operational leaders there, but really, how do we incorporate more of our lean tools into that? Next, we're trying to work on developing a single source of truth, again, using our Epic tools to develop a access and flow dashboard that has all of our key metrics that support the work that we're doing, but also would allow all of our leaders to access it, but all of our leaders below those leaders so that they have access to real-time data to help them in their decision-making. Again, there's going to be a continued and really robust approach towards hiring and training for current staff vacancies, both on provider and our nursing side. And then again, as always, we are going to continue to collaborate with our network partners, the Department of Public Health, as well as our city partners. I'm really trying to improve placement options for our hospitalized patients, both for med-surg, but also psychiatry as well, knowing that the lower level of care psychiatry patients also remains at a high level. And with that, Jillian and I are happy to take any questions that you may have or any comments or discussion. But really where we stand today with regards to access and flow is we recognize that this is a challenge. We definitely are at an unprecedented time with some of our flow throughout the hospital. But I think we remain incredibly optimistic given the strong collaboration. I think really the thoughtful approach our leaders have taken. And I think you can see some of the successes that we've had in many of these areas demonstrated on the previous slides. And so we are really looking forward to the next several months and a year from now when we can come back and present, I think, more data to you and I think more of a positive trajectory on some of those areas that remain red.
I can check the public comment line. Folks on the line, we are on item 4. Please let us know by pressing *3 if you'd like to make any public comment. *3. No hands, commissioners.
Good, thank you. Very comprehensive. Commissioner Green. I think you're on
mute.
This is such a terrific report, and as you say, it really does reflect the collaboration that's so characteristic of the way you work there at the General. I also appreciate that I could read slide 3, which is great because sometimes those are small. I have two simple.
I did increase the font on it this time.
You did, didn't you? It made a big difference. So two quick questions. One is on slide 7, greater than 10 RESUS. What is RESUS patients? Is that resuscitation? What does that stand for? It's on your PDSA. It's the far right. When you're going to go on diversion. I didn't know what RESUS meant.
Oh, I believe that's resus.
Yeah,
Or resuscitation.
resuscitation. Yeah.
It's resuscitation. Okay, I wasn't sure.
Resuscitation, yes. Sorry, it was an acronym. And really sort of the approach, in addition to sort of, again, just allocating hours in terms of when they can be on and off, they've also, in the emergency department, thought about how they will leverage the space down there to accommodate the increased number of patients that we have in the waiting room, but also I think that are waiting in bays to be seen by providers.
And then the other definition is, what do the various red light, green light on your 12, 13 slides mean? Because you've got some reds where it sounds like you're still doing, you're doing work. Is there any particular definitions that go with those?
Yes, great question. So green means that we have been successful in fully implementing that intervention or PDSA. Red means that even though we might be close or might be working on it, we've not achieved success in each of those areas. The reason I think the vast majority are red is because they're still all ongoing and we haven't achieved our full success, or at least what our aspirational goals are for several of them. But I think really what we were hoping to highlight is that there's just so much work going on by our Department of Care Coordination, both internally but also externally. I think really just showing, the really tremendous effort from many stakeholders to try to improve our lower level of care patients.
That's great. Well, I had just three questions, and one is probably my lack of knowledge. It is really fabulous the way you're using the med-surg nurses. I think that's so brilliant. Is the space in the ED limiting your ability to really have that solution as maximally effective as it could?
Jillian, would you like to answer it, since it was your brilliant idea to utilize med-surg nurses there?
I feel that given the space, we have been able to use them as best as we can. We actually have decided that Pod C is where we will board all of the med-surg admissions. And so those nurses are now based in Pod C, which allows us to utilize the emergency room nurses to fully open up Pod A, B, as well as to support triage, which again is supporting flow. So far, so good. And it's been well received by the staff. I think in terms of morale, when you're an ER nurse, you're not really there you don't want to take care of med-surg patients. You want to do that ED nursing. And so they've been very receptive to it.
That's great.
And I didn't show this data, but we've only been doing it for about a month. But what we've actually been seeing is that, we do discharge a lot of patients from Pod C, patients who are boarding there. We've actually seen earlier discharges since the result of the med-surg nurses being there. One, because they have a better understanding of med-surg patient needs, and the teams have, really good dialogue with them down there. They're there on a consistent basis. And so we're starting to see discharges much earlier in the day, which again, overall helps to increase flow, not only in the ED, but ultimately throughout the entire hospital.
Great. And then with your time to next available appointment, we talked a lot about the no-show rates and what's being done to try to improve that. As you look at improving this number, what impact do you think that improving the utilization of appointments will have on that? In other words, I know you're doing a lot of things. More and more patients are signing up for Epic and getting reminders and so forth. And I know you have outreach from several clinics. Do you have any sense of how, if you just were able to fix that problem by 20%, how it might affect your TNAA results?
Yeah, that was, one of the concerns that was raised by several of the clinics. One of the things we have noticed is that I think one of the reasons why our clinics had significantly long wait times was that there was a lot of rework that is done. So for example, it was very characteristic for many of our clinics that if a patient no-showed, they were automatically put back into the queue, sometimes 3, 4, 5 times. And so that definitely increased and lengthened our wait time. So by shortening the no-show rate in several of the clinics that you've seen, I think probably in some of the PIPS reports, and with these coupled with these other interventions, has actually helped with the wait time even more so, because it just reduces that redundancy and that reworking from the no-shows.
Good. And then the last question I had was, it looks like 4A, you're really full all the time. I'm thinking back over the various census reports. Can you talk a little more about what the options really are for placement at this point, assuming that Laguna is a little bit uncertain at the moment? And I mean, do you have people that if you had 60 beds instead of, I think, 30 in 4A, that you'd be able to accommodate people? In other words, and how do you choose who goes where? I know you've got these other components of the DPH helping out, but what's your sense of where you think you're going to be able to make the most progress, and which outside the general organizations you can work with best to try to really move this along?
Yeah, no, great question. So if you look at our lower level of care days, our team has broken it down in a Pareto chart, trying to sort of identify what are the highest or what are the most common reasons for why someone may not be able to be discharged. About half of our lower level of care patients, it has to do to skilled nursing facilities. And so since our lower level of care patients on average right now is about 40 to 50 patients a day, if we were to get 60 beds in the community, that would be a tremendous help, I think, in reducing that number. What has worked, I think, one, we have a contract with Chinese Hospital in terms of skilled nursing facility beds over there. We are working with our partners there to try to improve some of their efficiencies and trying to help provide some resources there with regards to some of our patients. We're working on trying to increase the number of beds there. I also know that the network has engaged another partner in the city to increase the number of skilled nursing facility beds as well, while we're waiting for Laguna Honda to be recertified. Our 4A team has really been tremendous. They're almost always at 100%. And they are pretty good about discharging patients back, usually to the community or to another level of care. Their discharges average about probably 1 to 2 per day, which is just slightly higher than the norm for other skilled nursing facilities. We do, it would be ideal if we could increase the number of beds there, but just given our space restrictions on campus, not in the cards at this moment. So our hope is that, with improving efficiencies at Chinese Hospital and getting this contract to go through with another skilled nursing facility, this will hopefully help decompress the system a little bit.
Wonderful. How many beds do we have over at Chinese? How many?
I believe it was 30. Is that right, Susan? Or it just got
23.
decreased slightly?
23.
But who's counting? Well, that's great. Well, this is really, really terrific work. This is so encouraging to see. And as I say, every time I come to one of these meetings, I am so massively impressed by the way you work together and by all the brilliant ideas and how well you're also able to execute them. So very encouraging report. Thank you so much.
Thank you. The kudos go to our entire team and our leaders and their leaders below them as well. So thank you.
Thank you. I found your report very comprehensive and a lot of work, obviously, in the past year. Just the thinking of how to take a different approach in the emergency department may be one of the reasons, as you say, that you've been able to show a drop. I do remember that a target in the past has been closer to 20 to 25%. So I don't know if you've abandoned that completely or.
No,
Yes.
EMSA has a goal of less than 30% for us eventually. They wanted us to first get below 50%, which thankfully we did this month. And then the next tier for us would be 30%. And I think it'll be far easier to get down below 30%, not in the winter. It's just, it's a time when we have high volumes anyway. So I feel optimistic that we'll be able to get closer to that a little later in the year.
And I think one of the things we've seen really encouraging news is with the additional staff that have been brought into the ED, along with the med-surg nurses there. And I think this collaborative approach from the ED leadership team and leveraging the PDSA on some of their busiest days and some of their highest census days, they've been off divert the vast majority of the time. So with ambulance diversion at low 20s. So we definitely know that it is possible with, I think, some of the right conditions, which we've been able to hopefully help set up in the department there. And then hopefully that will be able to be sustained over the next couple of years as well.
You know, the emergency department, we actually built out 3 pods. So I mean, 3 pods were built, uh, and and I'm just wondering on the long-term basis, because it sounds like that's a good use of seed. Uh, and Was that what we thought when we first built it, or is it that there would be less diversion if we took all 3 pods and added more people? But then, of course, we would create another a problem. Uh, so have we abandoned the idea of expanding the emergency greater and decided that C would now be a holding ward?
Do you want to answer, Susan, or you want me to? I'm happy to tackle it.
Well, I can try. I mean, I think, the emergency department, I wasn't around when we were planning for the new emergency department, but I know we were designing it, to be almost twice as large as the old emergency department, exactly because we wanted to be able to accommodate disasters and emergencies and also to stay off ambulance diversion. As with any move, you learn a lot of things when you move, and just moving into a larger space did not solve the ambulance diversion problem, as we know. So I think, in answer to your question, Dr. Chow, we did not move into our new emergency department thinking that we would create a med-surg unit down there. That was never the plan. It turns out that we have one right now, and we do tend to board a lot of patients in the wintertime. And it's very complicated, right? The flow issues that impact us on the back end, definitely translate into the emergency department. So the key reason we have so many people boarding in the emergency department is because we can't discharge patients as readily as we want to on the other end. So it's just a very complicated flow process. And I just want to take the opportunity now to thank Jillian and Luke for all the work they've done to lead this work, because there are so many pieces to it. It's so complicated, so many moving parts. And I think we're doing the best we can under some very challenging circumstances, both in the pre-hospital environment and then in the post-acute environment. How did I do there, Luke? Anything to add?
You said it better than I could have. The only thing I would add is that pre-Epic, one of the things that the ED had talked about was having an observation unit, which many EDs do. Pod C was potentially considered as an area that would be an observation unit. And so not that we want med-surg to be that OBS unit, but there were some thoughts in the past that could be where patients might be housed for a little while who needed a little bit longer time to be observed.
Thank you. Now, on a smaller point, and most of this is technical and going back to abbreviations, I was struck that through the course of a number of other sections, also we have a number of abbreviations, and these aren't medical abbreviations because those all have kind of a glossary, right? So I'm wondering, I was actually on another board from a unnamed insurance company that actually had the same problem when looking at all of their documents, and they created a glossary of about I would say, let's see, they're double columned and about 1 page. And it really has helped because each of the areas, from quality assurance to utilization, whatnot, they've all got their own. But once we have it, then it was easy, and I just did this weekend, to go back and not ask the question again, like, what does CN mean? Or what does AOD mean now? But quickly look it up, and it just made sense. So I'm just wondering if it might make some sense, because there are a number of abbreviations under many of your reports that I know you all know what they are, but I'm not sure. Maybe Dr. Green does, but I don't remember all of these. And I'm just wondering if a small a glossary might be helpful. I mean, you could just start one, and every time there's a new acronym of some sort, we could add that, and when others aren't being used. But it might be helpful and avoid some of the questions that we have in terms of confusion. There's another one, for example, MCI. And to me, I think that was a telecommunications thing at one point. But it obviously is.
That was not as nice. It's mass casualty.
Oh, okay. You see? So,
But it's a wonderful suggestion, and I think we can definitely work on putting something together because, you know, even when I started, and I think many of our other young leaders or people within the organization also struggle with the acronyms, and so it could be a useful tool for education, and then also a nice reference as well. So we can definitely work on that and sort of at least come up with at least one page of our most common terms that we get asked questions on in terms of what they mean. So thank you for that.
well, thank you. That would just be maybe something maybe more to our convenience. Commissioner Green, would you think that was a nice idea?
Well, I think when we get a non-doctor on the panel, it would be really helpful. I knew it's most of them were, but when I don't know, it's so much fun. If you ever look up any of these abbreviations, they, on the internet, they have this long list of all the things. And I go, oh my gosh, it's like an education into itself. Then you go on these tangents where you're looking up what else it is. It's actually kind of fun if you have nothing better to do. But it is quite interesting, and I think that would be great when we have someone who isn't in. I mean, I knew about the administrator and the charge nurse and all, but for someone who isn't in the medical profession, which if Commissioner Christian rejoins us, that would be the case, would be really helpful.
Right, and I think there's been a great effort to help with some of your policies, being able to name the acronym and then use the acronym throughout the policy. That also I think has been very helpful. So just notice that all the minutes seem to carry a not large number of them. And Commissioner Green's right. Some of us can guess most of it, but I had forgotten about the non-professional even that could really benefit from that. Well, we have thank you for this update. I would think that two items are really important. I think that maybe you want to do a half-year follow-up, which would be, of course, we look at the emergency every month, but the work you're doing with the lower level of care might deserve, I think, highlighting just like you did today on that. And matter of fact, that's probably the one that I would say really would be helpful for us to see, and how many of your initiatives have actually then turned from red to yellow or green. And I guess those pages, this is for me who's I guess getting worse, red, green, colorblind, but those are actually reds.
Yeah.
Okay, because
Yeah,
on
sorry.
they look green on the paper.
Yes, but we're happy to come back in 6 months to give you an update on the lower level of care. And then just even a quick update on the other metrics, just to let you know where we are. Because I definitely think specialty care wait times will definitely be green by that time. And then hopefully we'll see some changes with regards to lower level of care patient days.
That'd be great. I mean, it's I think it's wonderful where the organization actually can critique itself as it did in its problem statement, and then really continue to work on it. I think that's very important to have done, and that just struck the right tone as I think we were reading this, and we'd be happy to see your progress in the next 6 months. Thank you.
Thank you both. Really appreciate your comments and feedback.
And we will have a regular schedule, or we do have a regular schedule of updates with all of our strategic initiatives. I believe next month you'll actually see our True North scorecard. So we'll review all of the metrics. And then, each month our goal is to have at least one of the strategic initiatives reviewed for you. So that comes at a regular cadence. So I don't actually know what the next cadence is for this one, but it'll definitely be within the next 6 months.
Okay, thank you very much. Great. And with that, I think, Mark, we could go on to the CEO's report, I think, right?
Sure. And if I can put a plug in for the glossary, it's helpful to the public. These documents live on the internet and the web pages forever. And when folks go back in decades, which often I'm asked to send documents, it's helpful to have that glossary. So thank you ahead of time if that's developed. Item 5 is the ZSFG Chief Executive Officer's Report and Emergency Department Newsletter.
Thank you, Mark. Good afternoon, commissioners. Susan Ehrlich here with your report. I do want to say with respect to the glossary, this is a perfect task for our new Chief Administrative Officer who will be starting in March. We'll make a full announcement of her presence, which is really exciting, but it's perfect for her. So thank you for suggesting that. All right, so I'll start with the narratives. We have a lot to report on, a lot of good news actually to report on this month. I do want to take a moment and just pause to recognize the significance of this date. And it has to do with the first item around COVID. So as of Tuesday, February 28th, that would be today at 11:59, the health officer will be rescinding the local health emergency, which has been in place since March 6th of 2020, as we all well know. So it's a very significant date. It's a lot we've all been through together over the past 3 years around the COVID pandemic. And, we've been in a different phase of the pandemic for a while now, but, this is a truly remarkable moment. We will have, as the local health emergency and some of its related health orders are being rescinded, there will be, especially one new health order that relates to masking in healthcare facilities and other high-risk areas that does continue to impact us. So, put very simply, our masking, by and large, our masking requirements on campus will not change. The only change that we will be implementing starting tomorrow is that it will be optional for staff to wear masks in non-clinical areas. Now, what does that mean? That means that any place where patients don't go. So it doesn't include, so clinical areas will still include hallways, elevators, the cafeteria, any place where we have patients, but in a conference room behind a door where we never have patients, then that will be a place where people may choose not to mask. The other change is that for patient support groups where food and drink is important to the function of the group, patients will be able to have food and drink. We haven't allowed that until now. We hope and expect that they'll mask when they're not actively eating and drinking. And then we still want to be very mindful of our room capacity guidelines. So that's the biggest change that we've been talking about. That policy that I just described will be the same throughout the Department of Public Health. And I think Grant is going to be issuing a message to that effect tomorrow sometime. So that's the COVID news, the big COVID news at this point. It is a little ironic to see that happening at the time when we actually are seeing the incidence of COVID cases rise in the community. The concentrations in the wastewater are going up, hospitalizations are going up a little bit, but as we'll see in the data, it's nothing like it's been at some of our highest peaks. Going on to the stroke survey, we talked about that a little bit. Just want to say what a remarkable thing it is to witness our stroke team in action and our quality team supporting them. There were 3 findings. They were relatively minor in the scope of the way these findings go, and we were recertified, which is great news. Item number 3, it was also wonderful to be able to celebrate the 40th anniversary of Ward 86 and the 50th anniversary of Ward 93. These are 2 remarkable clinics and services that serve our patients and our community in very special ways. I actually learned from the Ward 93 celebration, which was lovely outside, right outside of Ward 80 and 90, that the clinic really started as a result of the Vietnam War and the veterans coming home from the Vietnam War being addicted to heroin. So it's just incredible that we've provided these services that are so important and were so groundbreaking at the time and continue to be groundbreaking in their practices and the, the new sort of standards that they set for the world, really, in the case of HIV. And I think that's probably also true for methadone, the methadone clinic. So that was lovely. Today is the last day of Black and African American History Month. You can read about all the things we did today. We had a very special celebration of 10 of our Black African American leaders, including Andrea Turner and Jillian Otway. Just beautiful oral histories from this remarkable group of 10 very diverse leaders. And I was very honored and privileged to be a part of it. And then last but not least, the Hearts event. I was sadly unable to go, but it was an incredible event by all reports and by all the photos and videos that I saw. It was at City Hall. The heroes honored were one of our patients and two of our nurse leaders who you know very well, Joan Torres and Merjo Roca. And you can see in the report also that one of the hearts was actually created by one of our nurses. So just a lot of really wonderful things to celebrate this month, and I'm really happy to have it all in one place and to be able to report it to you. And I'm happy to answer any questions about any of that before I go on to the data.
Commissioner Green, any?
No, it all sounds wonderful.
Okay.
Well, I was going to, and I raised the question, in the health orders on health facilities, they were not going to require masking for visitors, but what is going to be the hospital's position about visitors?
We require, we require visitors, staff, patients, and visitors to mask in all patient areas.
Okay, and that will continue?
Yes.
Yes.
It absolutely will.
And is that going to be the citywide policy then?
I believe that health, it will be true for DPH in clinical areas. And it is up to hospitals to decide how they want to manage this themselves. They still have to mask in clinical areas. How they want to, require masks beyond that is up to them.
Okay. I also wanted to note that and congratulate Dr. Elena Fuentes-Affleck on her award, and didn't want that to pass without our thanks to all the work she's doing.
Thank you. I'm sorry I didn't mention that. The 2023 Joseph W. St. Jem, is that how you say it, Elena? St. Jem Award is an incredible honor for her, and we definitely celebrate that with her. Thank you, Elena.
Thank you.
Thank you. Okay, we'll go on to the remainder of the report. We'll look for public comment after the end of your report.
Okay, so we start, as always, with our graph of our surges. There have been 7 of them so far, remarkably. The first one is off the page to the left, but you can definitely see the trajectory of how things are going. We've had a little bump up recently, but nowhere in the neighborhood of the surges that we had earlier on. The average daily volume in the emergency department and the admissions are pretty stable. So on the next page, we had quite a discussion already about the ambulance diversion, and for February, 45.3% as of today. We'll get the final number after today, but doing remarkably well there. The nut that we still need to crack is around the leave without being seen rate. That still remains unacceptably high in the 7 to 8% range. And it's really, it's a result of the volumes that we have in the walk-in areas of the ED. It's especially a problem overnight. That's when the leave without being seen rate is highest. So I think, in the spirit of compassionate, data-driven improvement, we're going to continue to work on that. We've been focusing a lot on ambulance diversion, and we need to really focus our efforts on this as well. Which fortunately, because of the med-surg nurses, we have more wherewithal to reassign ED nurses, NPs, physicians all to the front end. So we can definitely address that. Other data, we've really talked a lot about sort of where we are. You can see, just skipping to the med-surg census, it's quite high. You can see that it's been at 200. Remind us that we're budgeted at 164. And so we're really well above our budgeted census. And the ICU also remains quite busy. So we're still dealing with winter-related volumes, and our expectation is that they come down in March and April, and hopefully we'll see that. It'll make it far easier to run the hospital. And the lower level of care data we talked about as well, so I won't go into detail with that. And most of the rest of the things haven't changed. Oh, I do want to say one other thing about the workplace violence. So we just implemented, thankfully, our new SAFE system, which is our new system for reporting events. It is far easier to report events and far easier to pull data out of that SAFE system. We're not quite at the place where we can pull out all the data we want in the way that we want, but we're really on the cusp of that. And I want to thank the quality department and Susan Brockovic, especially, for leading the charge on getting this system in place. So we're going to see more events, I predict, in the upcoming months, more workplace violence events, because people will be reporting more. That's actually a good thing. And it will be a while before we stabilize kind of the reporting and the trends and the trajectory in those numbers. I would say over the next 6 months or so. So I just wanted to give us all a heads up about that. We see this nice, generally a downward trend in workplace violence activity, but you'll probably see something different starting next month and going beyond. Any questions?
Mark, you want to check for public comment?
Yes, sir. Folks, we're on item 5, the CEO report. Please press *3. Again, *3 if you'd like to make public comment on this item. I do not see any hands, commissioners.
Commissioner Green, any questions?
No, I had no questions. Thank you.
I had a question on page 13 about the average daily census. Where is the observation census then? It's in one of these categories?
Good question. There would be observation within the med-surg census. There would be observation days. We haven't broken that out. I don't know, Luke, if you have a better sense of those days than I do.
Great question. On average, we have about probably 2 to a max of 4 patients who are in observation status at any given time in the hospital. And it's been pretty consistent over the last year and a half.
So that's included in the med-surg census.
Yes, that's correct.
And in the med-surg, I think it was in med-surg, but in terms of the physical number of beds, how do we exceed the number of physical beds?
The way we do that is by boarding patients in various locations in the hospital. So the patients that we talked about in Pod C of the emergency department, those are technically med-surg patients, so we count them in the census. We often have patients, every day we have patients boarding in the PACU, so patients coming out post-acute care unit. So patients coming out of surgery, they'll often stay, or sometimes they'll stay in the PACU and then be discharged home. And then the other place that we board med-surg patients is in the ICU. So, as we have patients step down from that critical care level, they'll remain there until they can get into med-surg. So it's a challenging balance, and this is what we do every single day. We have at 9:40, we have a leadership meeting where all of these data are reviewed and we figure out, what the balance is and how we're going to manage it that day. It's quite challenging.
Yeah, well, I can see that. No, thank you very much.
Sure.
Very helpful. I don't have any more questions unless Commissioner Green came up with any more. We could go on to our next item.
Yes, sir.
Well, the emergency room little newsletter is so wonderful, and I really like that it starts out with so much information about wellness. As we come down to the end of this pandemic emergency, there's still a need, and I was pleased to see page 1 there.
Very good.
All right. Thank you again, Dr. Ehrlich. Item 6 is the ZSFG hiring and vacancy report.
Who's going to present?
You're on mute.
Sorry about that. Good afternoon, everyone. My name is Emma Perez, and I believe Carrie's listed for this item, but we are actively seeking to fill the HR manager position. So I'm the clinical team supervisor. I've just joined about a month and a half ago, so I'll be reporting out for this item. Based on the report that you received, the hospital vacancies increased to 12.49 as of January 2023, which again is up from 12.36 in January. We've hired a total of 18 employees between January 1st and January 31st in various classifications, including RNs, and had 5 separations during that same period, of which 2 were retirements. The increase in vacancy rate can be attributed to positions being filled through reassignment, which creates a cycle of new vacancies. We've also had high turnover in HR staff, so that has increased workloads and impacted hiring timelines. But we are in the final stages of selection for HR analyst positions. And at the time, we expected to have onboarded additional positions and staff in March to assist with filling vacancies. And I'm happy to report that we have hired at least 1 analyst position here at Zuckerberg with another selection already made. So we are actively making selections. The RN vacancy rate has increased to 12.36% this past month. We have ongoing challenges in filling ED and critical care RN experience vacancies. We heard from nursing management that there's been a mass exodus in the ICUs across the country. And so we're now seeing the real impact of COVID on staffing and nursing. So our RN recruiter continues recruitment efforts through multiple tracks. We've been able to mitigate challenges in hiring nurses by hiring 8 P103s this past month. Hiring managers continue to use application review, which speeds up the process of selection. In addition, the union has agreed to pause reassignments for RNs for 6 months, which allows us to go directly to the eligible lists. And there's also an RN/social worker/behavioral health clinician hiring event that is planned for March to do mass hiring. And we will be partnering with leadership from DHR, Department of Human Resources, for the city, SEIU, our labor partners, and nursing to help make this a successful event. We now have 2 target dates for 2 different events. One will be targeted for March 25th as the social worker event, in line with Social Worker Month in March, as well as target date of April 8th for the RN event. So planning is still underway for these events. HR conducts weekly and monthly vacancy meetings with hospital executive team or program managers to review hiring plans. As far as the RN hiring status update, the emergency care unit has 20 experienced vacancies, which is 21.7% of RNs in the specialty, and candidate selections are pending. As we've mentioned before, there's just very few candidates that are applying to our recruitments. Critical care unit, 11 experienced vacancies, which is 9.71% of RNs in the specialty, with 3 selections made with target start work dates in February and March. For our med surg unit, we have 36 experienced vacancies, which is 10.50% of RNs within the specialty, with 3 manager selections in progress and start work dates in February and March. Thankfully, our OR unit has 0 experienced vacancies, so they're all filled right now, which is great. As far as training updates, the next critical care training program is anticipated for April 17th with a cohort of up to 8 positions. They've received a robust list for the RN training program, so that's good news. The next OR training program is anticipated for March 4th with a cohort of 2, and in March 18th, another cohort of 3. The next ED training program is anticipated for March 19th with a cohort of 10. And the med-surg training program is targeted for April with a cohort of 10. We also have some highlights for non-RN hiring for ZSFG. We hired a nurse manager for quality management, 2 5502s, which are DPH project managers for capital projects. They're working on renovation of ZSFG Building 5, the Ambulatory Care Center. We have 3 porter hires in environmental services and 2 porter supervisors in environmental services. With regards to your question about tech layoffs and the impact on HR positions, we have a list now with actually a good mix of internal and external candidates. So potentially we are seeing some of those impacts from the tech layoffs there. And we are actively filling our HR positions. We have made about a handful of selections department-wide, not just for Zuckerberg, but it is our priority to fill all additional vacancies as soon as possible. And then you also had a question about travelers and vacancy rates, especially on night shifts. So we have used registry and continue to use registry to bridge the staffing gap created by the vacancies. The staffing needs tend to be greater in some areas on the night shift due to shift assignments that are contractually done by seniority. So senior staff tend to want to work the day shift, which creates vacancies on the night shift, and the night shift positions are usually filled by newer staff. So that's my report for today. If you have additional questions that I can help answer, please let me know.
All right, shall we look for public comment, Mark?
Sure. Hi, folks. If you would like to make public comment on item 6, the hiring and vacancy report, please press *3 now. *3. No hands, commissioners.
Thank you. Commissioner Green?
Well, thank you for the report and for the answers. There's one thing I'm kind of curious about almost in an ongoing way. You know, when we used to have more public comment in person from staff, they talked about, short staffing, which is different than vacancies. So do you have any sense of, when you see, for example, that 21%, 20 nurses are nursing vacancies in the emergency department, with the people you feel in either travelers or registry, and obviously if there's a shortage in critical care, that's a whole other area. At what point are you really under capacity for staffing, where it would not only raise concerns from your perspective, but also trigger more kind of vocal positions from the staff themselves? Because the one thing we would hear repeatedly is not so much about vacancies, is about shifts that were understaffed. So how well are we doing filling these making the staffing whole shift to shift, especially in the critical areas of vacancies?
Thank you for that question. I would like to have our nursing leadership help respond.
Sure. Commissioner Green, that's a great question. And to your point, the nursing staff are always very vocal about their feelings related to staffing. As you know, we meet with them in all of our areas monthly. And so this is a hot topic for discussion. And with the vacancies, it is a struggle. I think, in the ED, for instance, there are times that we have to close some of the pods in terms of the beds in pod A and B, because we may have sick calls and we just do not have the staff available to backfill and fill that gap. In med-surg, we've had to have break nurses take assignments, and so they are not available to support the staff with breaks. In my area in labor and delivery, it is an issue as well, because and to your practice, once that bus drives up and we have those moms get off and they all come at the same time usually, it can be a challenge. And staff are not able to do breaks and are mandated to stay over their shift until that individual that we have coverage for that labor and delivery patient, and or we have someone to go into the OR to, take that nurse's place in that C-section. And so, um, you know, with a vacancy rate this high, it is an issue for us. And, to Emma's point, we recognize that we are the training ground for the future nurses. We do not have the luxury of having a lot of experienced nurses leave Kaiser, CPMC, or UC to come work in public health. I mean, that's just the reality of what we're dealing with. And so for us, we've always had to do training programs. And I think this is demonstrated in the number of training programs that you see us doing yearly. In critical care, it's at least 3. In the ED, it's probably 3 to 4. In my areas, I usually do 2 to 3 as well, and definitely in med-surg. We have a really robust eligible list of new grads that are interested in working for us. A lot of them have actually done their rotations here. We contract with about 15 schools of nursing, and so they are familiar with us, we are familiar with them, and they definitely want to work for us. And that's the population that we target, and when we're looking at filling some of these vacancies. And so it's really important for us to get those lists for training program applicants.
I just want to add to something that Jillian, I agree with everything Jillian says, and she's just a tremendous leader in managing this really challenging environment that we're working in. It's the same for every hospital. We're not alone, but it's been hard. I will say there are 2 kind of things that I look at to kind of think about how we're managing, relatively over time. One is, since May of 2022, we get a daily report of how we're staffed in the ED. And I will say, before November, there wasn't a day when we were at core staffing, and that was because of the vacancies, and because, before that time, we couldn't even get registry staff to come here. Since that time, we're doing much better. But to Jillian's point, it's not because we have so many vacancies. It's because we're more easily able to get registry at some expense, I will say, but it's relatively better. The same thing in med-surg. Before that time, we could never open our H58, which is our surge unit. We didn't have the staff to do it. Now we can't open it entirely as we would like to, and we should every day, but we can usually open it, with 8 to 12 patients, which really helps us a lot. And again, it's because, we have registry, we have the training programs, which are our lifeline, as Jillian was saying. So things are better. They're not perfect by any means, but it's not quite as bad as it was, in the summer of last year, extending to the November or so of 2022.
Well, absolutely. This is unbelievably challenging in all areas. And I remember being so impressed when public testimony came along, obviously 3 years ago or so. And I think you had all the numbers about, because they would always bring up things like not getting breaks, all the things you were saying, Jillian, about not getting breaks and having to work overtime and so forth. And it was really, I think, impressive that leadership not only knew about it, but also had all the data and was analyzing it and doing their best to try to find solutions. So I don't know the extent to which it would be helpful for us to hear about this as part of this report, but I would be curious if there are any red flags that ever come up where you're really going through a period of time where we're likely to hear in public testimony that there's an issue, that core staffing, and there's no question that the core staffing is appropriate for industry and all of that, because that's sometimes in my place I always hear that they've understaffed core staffing. I never got the impression that that was the case at the general, but it would be helpful maybe if there are any issues that you guys identify to hear a little bit about them.
We can definitely put that together for you, Commissioner Green.
Thanks. Yeah, and I really appreciate the work. It is not easy at all. Don't steal any of our labor and delivery nurses.
Thank you.
I have an HR person I can give you, but no nurses. So sorry.
Oh. In line with what Commissioner Green was saying, I'm wondering, because in the testimonies that we had prior to, and maybe that's the one saving grace of COVID, was that we don't have these mass appearances before the JCC. There was discussion, however, about them going to the state. So whatever happened to all of those issues, or I don't know if they're called complaints on their part, or they were just notifications to the state about us being out of compliance?
Susan, would you like me to try to answer? I'm not going to say to you that it's gone away. What I think is happening is that we are meeting with them, and we are discussing these issues. We've had a number of arbitrations and mediations with DHR and SEIU to talk about staffing, to talk about, possibly supplementing some of the models that we have in existence in terms of staff in the critical care area, for instance. I know this week we're going to be meeting to talk about the birth center and breaks and mandatory overtime. Those numbers obviously have gone down, as I've said, but they had this on the books since August of last year, and so we're going to meet with them this week to discuss it. So I think that has changed for them, and that is the forum that they tend to come to the staff to talk about these issues. And we are trying to be as receptive as possible outside of the bargaining arena in terms of meeting those needs. And obviously they know what's going on around the country. They are fully aware that San Francisco General is not unique in a sense of having staffing challenges. They are working with us. One of the things that we're very proud of is this partnership to do this mass hiring. We're actually going to be holding it at SEIU headquarters on Rhode Island. And so the two events that Emma mentioned will be there. And, I think, again, it's the partnership that we are trying to build and to work together. And so maybe that has changed a little bit. I know that they still go to the service. Is it the commissioners that they went to one of the
Civil Service Commission?
Civil Service? Yeah, they did go, I believe, a month or two ago to talk about staffing. And I know that HR Luana will be going to address some of those issues as well. So.
And you mentioned in your report, so this may be part of the union working with you. How does pausing reassignments for RNs for 6 months help you?
So that allows us to actually bring in staff that are on an eligible list, and this would be new staff for training versus taking staff from one area and moving them to another area, because we're really not making any net gains. All we're doing is moving people around. So for instance, I would be moving from med surge to the ED or to critical care, which would mean that med surge would now have a vacancy. And so that pause will now allow us to access new staff that are on lists that are interested in working for us, as well as per diems. We've had a number of per diems that have started working for us that are interested in taking permanent positions. And so we would be able to hire those individuals. We would also be able to hire individuals that are unit clerks, that are SPD techs, that we have helped to support them going back to school to become a nurse, and now they want to continue their employment with the city, and they can't get in because we're constantly doing reassignments, and they would not be considered a reassignment because they're not in the same classification. They would be considered a new hire. And so this allows us to, again, access that list of individuals that are interested in working for us, promotive appointments. It's really helpful in that way.
Well, very good. So it does sound like, as you were saying, there's dialogue and perhaps much more cooperation to try to not just meet the national, but our local needs.
We're really trying, and I hope that everybody doesn't show up next month. But I mean, this is where we are right now, at least.
Okay, no, thank you very much. I mean, that was, I thought, very helpful to get the perspective of how well and the processes that you are now using to try to answer our nursing shortages, working with the nursing union too. So thank you.
Thank you.
If we don't have any other questions, we can go on to the medical staff report, Mark.
Sure. And just to note that moving forward, the in-person JCC meetings will take place at Carr Auditorium for two reasons. One, for hopefully for COVID prevention, because it's a larger room, and to prepare for the onslaught of possible staff public comment. Item 7 is the medical staff report.
Hello, my pleasure to present the medical staff report today, Dr. Chow and Dr. Green. So as you can see, we had a great clinical service report at our February MEC meeting. It was the anatomic pathology service report presented by Dr. Nishimura, the service chief. And he presented a very comprehensive and also very efficient report, just going through the remarkable way that anatomic pathology supports all areas, their presence in the operating room, their really fantastic leadership as a training program, a training site. And then they, also talked about challenges both with staffing for specialists, that they collaborate, fortunately, with our colleagues at UCSF, and also talking about, as anatomic pathology gets more complex with more send-out tests, how they are working through that. I think that Dr. Green had sort of a three-part question that I will address now. So the first part was, are there protocols for notifying providers about abnormal or malignant results? Yes, so pathology has a critical value policy, and they have a number of things that are considered critical values, including unexpected findings, especially unexpected cancer, and any change in diagnosis, from the initial frozen section, for example, or anything that may be initially communicated by phone. And so they make sure that they contact the clinical provider in those cases, and they also track that. I will just say that not every malignancy diagnosis is considered a critical value, because many times the procedure is being done specifically to look for malignancy, and malignancy is suspected when the pathologist, looks through the medical record. But it is their practice, if there is a new case of malignancy, that they actually call all of those. The second question was, how do they make that work, especially when the providers rotate off service? So it is part of their policy that they will reach a provider who is, attached to that record. So sometimes that, can take a little bit of doing, but they will, continue calling and reaching out until they meet someone, until they reach someone. And then what other safeguards are in place to ensure follow-up? So one of the things is that they actually track their compliance with calling the critical values. And so that's something they report to PIPs. And then as a backup, in addition to directly notifying the provider, all abnormal results are also flagged in Epic. And communicated. Any abnormal will show up in a provider's inbox also, to look at it, make sure that they are reviewing it. So there's a few layers there to try to make sure that all the important abnormal results are communicated. I would be glad to take any questions about the service report.
Let's look for public comment, Mark, and then we'll go on to questions.
Sure. Person on the line, we're on item 7, the medical staff report. Please press *3 if you'd like to make public comment on this item. *3. No hand, commissioners.
Thank you. Commissioner Green, any other questions?
Yeah, well, first of all, it was a wonderful report. And I thought it was incredibly interesting also how to manage some of these send out tests, because I was noting the thyroid, for example, there are so many individuals that have had partial thyroidectomies when they really didn't need it. Now that we have this technology, and it says that next year you're going to try to get a contract, but it seems such a shame that, surgeries could be avoided if only we could be more, have some of these things more available. I think this is really helpful. I always think about these things because, pap smears end up in my inbox like, snowflakes in winter. And sometimes I really wonder, what if it wasn't red, or what if I'm, zoning? And I do get lists from our path department that I double check. I have a giant folder here on my desk that I go through every month to make sure that I haven't missed anything. But I find it so helpful and time consuming that, to make sure, especially something like a cytology is followed up on correctly. And I know it can be really challenging. So I'm glad to hear there are systems in place it's a huge, huge book of business that you're dealing with in pathology. And I'm glad to hear that everybody has thought this through, and hopefully we'll get more access, especially to those thyroid tests that are so valuable. So yeah, those were really my only concerns about the feedback loop, really.
Yeah, I found it a very fascinating report, and to understand also the complexities of anatomic pathology. I remember as a first year resident, I guess, rotating through pathology was much more simple. And, you just sliced and looked in the microscope, and that was sort of it. Clearly, a very well run department. So I think we can go on to the rules and regs that you say are changing, or that you would like change, and a recommendation, which I think, Mark, right, it has to go to the commission.
Yes, sir. So your vote would be a recommendation that the full commission approve it.
So I think why don't we introduce the topic, and then we can make a recommendation.
Certainly. I am requesting your recommendation for approval of the clinical service rules and recommendations for anatomic pathology, which the department went through and reviewed. They had recently updated them in 2021 and went through again to and make sure that they did not require any additional updates.
Okay, so is there a motion for such?
Move to approve.
And I would second. So I believe that carries the recommendation.
Yeah, it sure does. Thank you. I will put that on the consent calendar for the March 7th meeting. Thank you.
Thank you.
Shall we move on to the next item? Is that okay, Commissioner Shaw? Sure. Item 8 is other business. A person on the line, if you'd like to make comment on this item, please press *3. All right, seeing no hand and hearing no commissioner comments, let's move on to item 9, which is.
Well, Mark, would you remind us again about the meeting that we are going to have in person? I know you mentioned it quickly. I thought this might be good just to re-emphasize. We are going to be meeting at Carr Auditorium.
Yeah, so moving into March, all Health Commission meetings will be in person, and the ZSFG JCC meeting will be held on the 4th Tuesday of the month, starting at 3 o'clock at Carr Auditorium. And we will continue to work out logistics, but that for the member of the public on the meeting, that's what we're going to be doing. Item 9 is general public comment. With the person on the line, if you'd like to make comment about something that's not on the agenda, press *3. Okay, no hand. And so now, everyone, we have a consideration for a closed session, item 10. Commissioners, that this would be for you to vote on going to closed session.
I would make a motion to go into closed session.
I would second, and I guess we look for public comment.
Yes, if you'd like to make public comment on going to closed session, please press *3. Seeing no hand, I will take us over. Give me 30 seconds to do this. Thank you, member of the public. You will not be able to see or hear us, but we'll be back after the closed session. Okay, we're back in open session. Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
Oh, and Commissioner Chow, you are muted. Give me 1 second.
Oh, sorry. Yes, I would second that.
Great. Since there's only 2 of you, then we can take that as an action. And then now we are consideration for adjournment.
Move to adjourn.
And I would second that. Looking forward to seeing everybody next month.